just wanted to talk about some confusion regarding back pain. Often people see their medical provider and be given a diagnosis for the lower back pain. Could be anything from like muscle strain, disc herniation, sciatica, piriformis syndrome. The reality is to pinpoint the source of the pain for lower back pain is easier said than done. With imaging like x-rays, MRI, CT scan, we get some good information regarding the anatomy of the spine, some of the wear and tear, but it doesn't necessarily pinpoint where the pain's coming from. So to do that, typically we get some sort of information on what may be the problem based off symptoms, physical exam, and imaging. And then from there, at times we have to do some diagnostic testing, whether that's a diagnostic block where we numb a specific structure, or sometimes we have to provoke a certain structure and try to irritate that structure to see if that's where the pain's coming from. So that's probably the best way to get the definitive diagnosis for the pain. Once in a while it's pretty straightforward and can be diagnosed, but often it's not as clear. Sorry about the wind. Hopefully it's not too noisy. Not sure how my audio is. So some of the more common things that we see cause pain, the intervertebral discs, they can be a source of pain. Just because there's wear and tear in a disc doesn't mean it's the source of pain. The way we test is we do a discography where we put a needle into the disc and we pressurize the disc. And if that reproduces the patient's pain, then we can diagnose it as a source of pain. Often with time we develop arthritis in the joints, in the facet joints or the SI joint. And the way we test that is we anesthetize the joint. We either numb the joint itself or the branches of nerves that go to the joint. And if that eliminates the pain, then we can confirm that diagnosis. If we're worried about a nerve root being pinched or damaged or irritated, we can block the nerve root by anesthetizing it with an epidural injection, and that can help pinpoint if that's the problem. Another diagnosis is spinal stenosis, specifically central canal stenosis. That one typically, rather than diagnostic testing, we will confirm with imaging. We'll usually see severe spinal canal narrowing. And then our actions depend on the severity. So if it's symptomatic, then we intervene. So if they're starting to have something called neurogenic claudication, where they have pain, numbness, weakness going down the legs as they walk, forcing them to stop or sit down, then we know that it's at a point that is worth doing something about. There's some other structures that are less discussed with your medical providers, and that involves the ligaments of the spine. One of the issues with those is we don't see those on MRI, so we don't often diagnose those, when going to the ER or maybe your primary care doctor. And the only way to really test those is to do this provocative test where you essentially stick a needle right into the ligament and inject the solution into the ligament. And if that reproduces the patient's pain, then we can confirm that as the problem. That waterfall got a little noisy. So often there is one primary main pain generator that we're trying to isolate. Other times there's multiple locations that are problematic. We try to tease out which is the most problematic and work from there. So determining the correct diagnosis is the key to proper treatment. With conservative management, having an accurate diagnosis isn't necessarily required. You can still put someone through conservative treatment with physical therapy, doing the correct exercises, and they can respond well with time. But when we need to do more aggressive treatments like interventional management or surgery, we want to pinpoint that problem spot before committing to those advanced procedures.